thank you for taking the time today to actually follow up on the topic that we had a while ago when you introduced to the community your general gravitation to research technology, how your team is incorporated in that. And today I would be super happy if you could specify and dive a little bit deeper into projects that you're currently working on, research projects.
How much time do we have?
That's a good question, actually, how much time we have. Endless, I would say, but let's dive.
Yeah, it's, I'm glad you asked the question. As you know, this is something that I think, as we had previously discussed and kind of ended the segment with, was, the concepts of artificial intelligence and technology and how that's impacting, kind of our ability to manage care and treat patients. Part of what we do here as a research institute at Advanced Heart and Vascular is truly select clinical trials that are relevant to our patient population. So the last thing you ever want to do is accept participating in a trial, but you don't have patients to enroll. So we focus on just the opposite. We know we have the patient population after reviewing the protocol that outlines who can be included and who would not be. And then we move forward from there. And in this particular instance, we're participating in 2 imaging trials. So when we're referring to imaging, we're talking about things like X-rays and CAT scans and MRIs. And in this particular case, we're talking about the evolution of CT, or computed tomography. CAT scan's been around for a very, very long time. Initially, when cardiovascular specialists would evaluate patients, everyone's familiar with what's called a coronary artery calcium score. Very simple test available in the community. Amazingly enough, you don't even require a physician to write a prescription to get it. You can walk into an imaging center. The test takes a total of 10 minutes. Within 10 minutes, they will give you an idea of whether or not you have calcium, which is one form of plaque in the arteries of your heart. And it's an extremely powerful tool at detecting what we refer to as subclinical atherosclerosis, meaning it's a screening tool. It's somebody with no symptoms. They want to know, do I have disease? So they go in there, and if the score is 0, then at least from a calcific perspective, they don't have calcified arteries. It's a very good predictive tool, in the sense that we know if the score is 0, that your likelihood of having a heart attack in the coming 5, 10, 15 years is exceptionally low.
Can I ask a quick question in between? Because I'm curious. A lot of people know the coronary artery. You hear that, and it's like a tiny little vessel, actually. Can you put a little bit of a scale, like, so that the imagination can kick in for everyone who listens to us? Like, what tiny vessel are we talking about? What's the dimension?
Technically speaking, some people classify the coronary anatomy as having 4 arteries versus 3 arteries. It's really an artery, a main artery on the left-hand side. It's called the left main. I usually describe it to my patients as kind of the base of the tree, and then it branches. And that branches then subsequently branches. And so the left main is an artery on technically the left side of the heart, that's responsible for giving rise to the left anterior descending coronary artery, which is an artery that goes over the anterior portion of the heart, and then an artery called the circumflex, which covers the lateral, and then in the back or the right-hand side, there's the right coronary artery. Each of them are equally as important. Some get a little bit more attention and notoriety just due to the way things are described. People are very common with the term widowmaker, which involves the main artery in the front of the heart. But from a dimensional standpoint, these arteries and their branches can be anywhere from, 2 millimeters all the way up to perhaps 5 and sometimes 6. Again, the further down you go, the smaller the branches get. So the main proximal portions or origins of those arteries tend to be the biggest ones. Arguably, the vessels that we work in with regards to putting stents and things like that are probably somewhere between 2.5 to 4 millimeters would be, the most common. But again, there are variances within that. So they're pretty tiny.
They are tiny, and they want a free flow, right? They want a free flow.
Sure.
Yeah, okay. So I think it's important to really have an idea, especially when we look at some pictures.
Yeah.
They may come, when they're on the screen, they appear like big, but they need to be protected, right?
Yeah,
by us.
for sure. And it doesn't take much to alter their function.
Yeah.
When plaque begins to get deposited in there. So yeah, to your point, with that evolution of the CAT scan, where we've gone from simply identifying calcium in an artery with not being truly able to visualize all the 3-dimensional aspects of a blood vessel, We've now moved into this arena where we have the ability to perform CAT scans where not only can we inject dye through an IV, it's done in an outpatient imaging center usually. We slow the heart rate down dramatically with medications like beta blockers. So a lot of people take those for a variety of conditions, mostly for heart failure or they had a heart attack. Sometimes they're used for hypertension management. And we slow the heart rate down. Why? Because to try to image the heart when it's going 100 beats a minute and these arteries are sitting on top of that, it's a very dynamic environment, difficult to do. So the slower the heart, the easier the acquisition, right? So now there's a technology. It's an artificial intelligence-based technology. It's an algorithm, basically. It was derived from tens of thousands of patients and millions of images, so to speak, where this artificial intelligence algorithm is basically using three-dimensional construction of blood vessels, not only to determine the amount of calcified plaque, but also looking at other plaque like soft plaque. Even more importantly, really not only quantifying, but characterizing the nature of that plaque. So there are specific things that can be looked at that would place a plaque in a much riskier category, for example, for rupturing. Obviously, the amount of plaque and the distribution matters. And based on using that artificial intelligence algorithm, what we're trying to accomplish in the clinical trials are something very simple. So if Brigitte walks into my office today and wants an evaluation, we judge you like everything else.
And it would come because they have symptoms?
Perhaps you have symptoms, perhaps you have risk factors, or perhaps even a family history of some sort of cardiovascular condition. And based on who you are on paper, meaning so you come in and Brigitte has high blood pressure, diabetes, smokes a pack of cigarettes a day because you're European, it's very common, I'm just kidding. And
we're flexible.
Based on those risk factors of who you are on paper, we can calculate a percent risk. Very similar to the artificial intelligence, arguably of the past, before computers, meaning you have hundreds of thousands of patients in something like the Framingham study, where you can look longitudinally what happens to these patients, right, who have these conditions over the course of time compared to a population of patients that doesn't. So that's kind of like the old school AI without the computer. So who is Brigitte on paper? Now, what we're looking to do is to transform our knowledge by using advanced imaging. So not only who you are, judge you based on that, now we can actually see your anatomy. So is seeing the plaque, is seeing the anatomy, is this something now we can quantify your risk better because we truly have an understanding of what's going on, not at, the level of just, I think I described it, don't judge a book by its cover type scenario, right? So on paper, we're looking at the cover, but the content, the reality is when you open up and start reading the chapters. And this is where we have arrived. And using this AI technology now has provided some very sophisticated imaging that we can review and discuss. But it will revolutionize and already has our approach to patients.
This specific study that you mentioned, how is it designed actually in like relatively simple words, knowing that it is, of course, complex?
Sure. So the way clinical trials are conducted, generally speaking, probably the most important component of that is a section in the protocol. It's called the inclusion and the exclusion. So inclusion is that you have to meet a certain number of finer points, characteristics, in order to be included. So one of the studies we're doing, for example, you simply have to be over the age of 18, coming and presenting to the office. You are, coming to the office, and you're having some sort of chest pain syndrome. And we are concerned that chest pain is due to an underlying problem with the arteries of the heart. The other one we're looking at is an at-risk patient population where men over the age of 55, women over the age of 65, who have fairly compelling cardiovascular risk. They're diabetics, pre-diabetics, metabolic syndrome, obesity, etc., and they would qualify for the study. The other side of that is the exclusion, right? So there's always an exclusion because we don't want to put people in harm's way if we can avoid that. So we know, for example, because someone's going to get a CAT scan, we're going to give dye. Dye can be what's called a nephro or kidney toxic agent, right? So you don't want to put somebody in and give them dye if they have kidney failure. So these are the nuances that go in. So when you walk through the door, that's kind of how we analyze you.
I'm very curious. Can you show me an example?
I'd be happy to.
Okay.
Yeah. So if we look here, what I
need
have
my
here,
glasses.
yeah, I probably should put mine on as well. So what we have here is a representative image of a patient. This is what is called their left main coronary artery, which you would see right in this area here. Okay, and again, as I described earlier, kind of a tree and subsequently gets smaller as you go further out. This would be the left vein artery, and then it leads to what's called the left anterior descending coronary artery. And they do a three-dimensional reconstruction of that image. And that image then provides you, as you can see here, a number of variables that the AI is able to quantify. So it quantifies what's called the total plaque volume, right, at different areas and then collectively within the blood vessel. We know that the higher the plaque volume, the higher the risk. Similarly here, it then differentiates the type of plaque, meaning low density, non-calcified plaque, total non-calcified plaque volume, and so on. It also has the ability, and I think this is one of the things for me as an operator, as an interventional cardiologist, there's a concept in cardiovascular medicine. It's called the Glegoff phenomenon. And what that is basically you have a blood vessel and it has a lumen, so flow. It's like a pipe and blood is flowing through there. And under normal circumstances, there's no resistance to flow because there's nothing obstructing it. The Glegoff phenomenon is a body adaptive mechanism that when your body has injury to the blood vessel wall and you begin to accumulate plaque, that plaque has to go somewhere. The phenomenon itself describes the adaptive mechanism where that kind of circular lumen now will become more of an ellipse in order to accommodate that plaque. So the adaptive mechanism allows the plaque to accumulate in the blood vessel wall without encroaching on the lumen. Like every other adaptive mechanism, there is a finite point where, the body can no longer contend with. It's why people who smoke cigarettes, don't get cancer for decades. There's adaptive mechanisms. The body is able to handle repetitive injury over time, but then eventually fails. So here you can see, and this is probably the most compelling piece of this information. So this is that artificial intelligence-based technology. You say to yourself, well, what is all this stuff besides, what we've quantified it as? You can see that the artery, which is the same artery here, has adapted and collected a significant degree of plaque in that phenomenon that I just described, where by doing so, it's not allowing all of this, if you could imagine, to be inside the lumen. So kind of pinching down that artery so that now it's affecting the blood flow physiologic parameters. But you can see here that, and again, these are what are called percent diameter stenosis. So people always want to know, well, how bad's the blockage? Well, this is something that can give us that information as well, based on, what we consider perhaps a normal lumen where the blood is flowing through, and then compared to the normal lumen in diameter, we can see that clearly that lumen is fairly shrunken based on the fact that that plaque is now encroaching on that lumen. So it gives us so much information. And when we see these sorts of things, as opposed to me just saying, well, you have high blood pressure, you have high cholesterol, we're going to treat those conditions, we make the punishment fit the crime, right? This is a person that requires further investigation.
As a European, that's saying I didn't know. We need to talk about that afterwards. What that actually is.
What that means?
Yeah.
In medicine or in society?
Focus. I have a question, if you don't mind.
Sure.
As a consequence of this results or this presentation, I would say, what's the next step for you, for the study, but also for the patient?
Well, again, based on the information, at least within the clinical trials, similarly to the way we judge you on paper, this is also looked at by an expert panel of physicians that also makes a similar judgment, but that judgment now is being made on actual disease, not prediction of what may or may not happen to you, actual disease itself. And by doing so and placing you in that category, those inherent categories, low risk, intermediate risk, high risk, as I said, the punishment will fit the crime now. So if you have something like this, I would imagine any cardiovascular specialist looking at this anatomy in the proximal LAD, otherwise known as the widowmaker, the accumulation of different plaque morphologies, this is a person where all hands are on deck. This is the person that you want the most aggressive and scientifically proven medication to prevent plaque rupture, thereby prevent heart attack. It's going to stimulate you now to investigate other vascular territories, right? So it's kind of a cascading effect where not only do we know that people who have vascular disease in one territory may have vascular disease in other territories, The more territories involved, the greater the risk. So this changes the game because it changes the dynamic of the intensity of therapy. And when we talk about therapy, it's not just drugs, right? I mean, we always talk about therapy, at least in our practice. The two greatest drugs in the history of the world are nutrition and exercise, right? So, and that's probably the hardest thing.
I like perspective. Even sounds scary for some.
But it is scary, yeah, because it's a self-responsibility issue, right? I can't, feed somebody. I can't make them go to the gym. I can have the conversation and attempt to inspire them to do the things that we know. But the most important thing we know scientifically is that nutrition can be equally as effective or even more powerful than pharmaceuticals, usually without the expenditure of not only an economic wallet biopsy cost, right? But also without the potential for side effects. So there's so much here, obviously, to unpack. But just to give you an idea, really, that's kind of where the next conversation moves. Obviously, we're following them with laboratory results and so forth within these clinical trials. One of them has a follow-up study, just like this, 2 years after the initiation of aggressive therapy. So we're going to be able to see those changes.
I really would like to continue the conversation also about the nutrition factor and the exercise factor, because it might sound scary for some who cannot go to the gym for whatever reason, but I think we should come up with some alternative ideas. I mean, New Jersey is beautiful. It's easy to take a simple walk, right? But now we're walking back to work. Thank you.
Very welcome. Thanks for the questions.